And Andrea?
You were going to post the slides, I thought. I apologize if that was an incorrect assumption.
I thought you guys would drive them, but did you want me to drive them?
Do you mind? I apologize. I don't. Thank you so much.
And it's the ones you and Margaret did together?
Yeah, so there's Andrea's slides. I sent you my slides.
Oh, her slides are in yours?
No, they're two different slide things. I sent you two slide things, one with Andrea's and one with mine.
Joe or Joe? Oh dear.
Connie, I can resend it to you super quickly here.
Yes, thank you. And are you first, Andrea?
Yes.
Okay. Margaret, I think I might have misunderstood, but
they are coming right.
Sorry.
So my first couple of slides are just sort of introduction slides. First of all, thank you for having us, and it's such an honor to be speaking with you. Please feel free to put questions in the chat, and I will try to answer them as I go along, or we can have a time for questions at the end. My name is Andrea Gepner. My clinical background, primarily as a nurse, was in oncology, and when I got additional training to become a nurse practitioner, and then that role, it's a provider role. I prescribe medications, I diagnose conditions. Yay. I started a practice in palliative care. I'd done extra training in palliative care as a RN, and then as a nurse practitioner have continued that. Next slide, Connie. I have nothing to disclose, no financial disclosures or conflict of interest. So let's get started. Next slide, please, Connie. What is palliative care? The Center to Advance Palliative Care, which is CAPC, you'll see that referenced kind of throughout the slides. They're a major organization. They have a great website if you're interested in looking them up. Defines palliative care as specialized medical care for people living with a serious illness. It's focused on providing relief from symptoms and stress of the illness rather than on cure. And goals of palliative care are primarily to improve quality of life for both patients and families and their caregivers of people living with serious illness. Oftentimes, if people have had experience with palliative care, they're most familiar with hospice care, and hospice was started the first hospice was in the UK in 1969, started by Dame Cicely Saunders, who recognized she was a physician and she worked with patients and realized that specifically with cancer patients at that time, once there were no more treatments that oncology or the medical system could offer, they were often felt abandoned, and yet they may have a very high symptom burden and ongoing healthcare needs, but when there were no more curative treatments or life-prolonging treatments, they kind of had nowhere to go. So palliative care started as hospice, which is for people who are at end of life primarily. As palliative care has grown, the definition has grown to include people at any stage of illness who might have serious, often life, might have a high symptom burden, either related to the disease itself or sometimes side effects of treatment. And so in palliative care, we typically work along with, for many of my patients who are still getting chemotherapy or other kinds of life-prolonging or sometimes curative treatments, we follow along with them and work with them to help with symptom management, again, work with our rehab colleagues around how they can stay strong and active through their treatments. And so in palliative care, our focus is really helping people live as well as they can and feel as good as they can wherever they are in kind of the pathway of their illness. The Latin root of palliative or palliate is the word pallium, which literally means to cloak. So to cover up symptoms or cover up distress, to reduce suffering. Palliative care in its best form is delivered by an interdisciplinary team, and you may see this referred to as an IDT. That typically is made up of clinicians like physicians and nurse practitioners, rehab specialists, including physical and occupational therapists. Respiratory therapists aren't on my list, but they are certainly a big part oftentimes of what we do in palliative care, speech language pathologists, and social work is typically quite involved in palliative care for support and integrated or get access to services that they need. And we often have chaplains also who work not from a particular spiritual or religious tradition, help support patients through some of the hard questions about meaning or what will happen to them if they get sicker or after they die that might come up when you're diagnosed with a serious illness. Next slide, please. Patients who are candidates for palliative care, as I said, originally the conception of palliative care was very much for people at end of life and sort of hospice. All hospice is palliative care, but as palliative care has grown, certainly not all palliative care is hospice. So really palliative care is for those at any age or any kind of point in their illness journey who need additional support around symptom management, either related to an illness itself or for treatment-related side effects. The diagnosis of patients who receive palliative care often include things like cancer. In the United States anyway, cancer is probably the most common kind of patient seen in outpatient palliative care, though in the inpatient setting, there's a much more wider variety of diagnoses. But palliative care can work well, can help meet needs of certainly people with neuromuscular disorders like ALS, Parkinson's and multiple sclerosis, advanced pulmonary disease like COPD, or I've worked with a few patients with hypertension, advanced cardiovascular disease. We see in our clinic all the patients at my institution at OHSU who are being evaluated for advanced cardiac therapies like heart transplant or a left ventricular assistive device, as well as things like end-stage renal failure, end-stage liver disease, and a variety of other diagnoses. We know that from research beyond it sort of making intuitive sense that somebody to work with you around symptom management can help improve quality of life. We know from research that there are objective benefits. For example, patients working with palliative care, both in the inpatient and outpatient settings, have reduced ratings of symptom distress on symptom management inventories. They report higher quality of life. We know that working with palliative care can reduce hospitalizations, both from the outpatient setting going to the ED and needing a hospitalization, as well as that working with palliative care in the inpatient setting can reduce length of stay and reduce readmissions. In some cases, working with palliative care has been shown to prolong life. So I know this Temel article from 2010 is rather old, but it was a hugely important work in the palliative care literature because it actually showed that working with palliative care concurrently with chemotherapy for non-small cell lung cancer patients with stage 3 or 4 disease actually had an overall survival benefit of 3 to 4 months compared to just receiving kind of standard chemotherapy. And that was a huge turning point that really opened up a lot of people who maybe in the past had not been open to palliative care, opened it up to the potential benefits of it, not for just helping patients to feel good, but actually helping patients live longer and live better. We also know that people who work with palliative care report improved understanding of their disease and improved communication with their healthcare team. So a lot of people with these complex diagnoses may not have a really good understanding of the goals of their treatment. I often, again, don't mean to keep coming back to oncology patients, but patients sometimes don't have clear understanding of whether the treatments that they're getting are with curative or palliative intent. They may not understand that when they get metastases, that's not a separate cancer, for example. And so we work with people to really help them understand their disease a little bit better and improve communication between themselves and their team. Next slide, please, Connie. In addition to benefits for patients themselves, we know that caregivers and health systems can benefit from having a palliative care team that sees patients. So that can include things like increased family satisfaction, reduced caregiver distress and caregiving burden in terms of the families who are helping care for people living with serious illness. In terms of health systems, there's reduced length of stay and reduced rates of readmission. And there's literature that suggests having a palliative care team, a specialty palliative care team to whom other clinicians can refer patients, reduces overall clinician distress and burnout. Some of these cases, I'm sure you've seen them in your clinical practices and the patients that you work with, can be very complicated. There can be some very tragic situations, and you want to do so much, and there may be limits to what you can do. And so having a palliative care team who can help carry some of the heavy, not just workload, but emotional burden that you may have in working with some of these really complex patients has been shown to improve clinician satisfaction and reduce burnout. Next slide, Bonnie. This is another graphic from CAPC, or Center to Advance Palliative Care, but some of this research around reducing rates of readmission, reducing emergency room visits, reducing, if you're in a skilled nursing facility, reducing hospital transfers, and even at home, reducing total clear. I think all of us in what we do, we understand that there is a financial component. And I saw your question in the chat. I will try to go back to address that. It's also all of these, not needing admissions, not needing ED visits. What that stems from is patients who feel better and are doing better at home. So I realize I'm talking a lot about dollars and cents, and for a lot of us, we understand there's an economic component, but those hospitalizations that don't happen are people who get to be at home with their families, are people who haven't fallen, are people who didn't get a bed sore, those kinds of things. So the cost savings is a concrete way to benefit or to measure it, but we go back to the person behind that not needing to go to the emergency room. I'm going to pull up the question in the chat. I apologize. Someone asked, please share a couple of questions. So one, in most systems, in our system, and I think this is pretty standard, a patient can request palliative care. And mostly most palliative care referrals are made by a primary care provider or an oncologist. In my setting in the hospital, typically a primary care referral, again, can be the request of a patient or family if they know about us, but is often made by the admitting team. So we get commonly from the intensivists in the critical care unit, if there's somebody who maybe they are struggling with symptoms, or maybe they have a sort of an unexpectedly severe or serious prognosis, have gotten sick quickly, or there's a lot of family distress. Anyone in the care team can refer, but typically it's going to come from either a primary care provider or an oncologist or other specialty, cardiologist or neurologist in the outpatient setting, or typically an admitting team in the inpatient setting. I think that one of the ways that in this terms of this question of please share how to decrease healthcare provider burnout, I think, I think that part of it is just having someone else to have some of these difficult conversations with families, and for you, as colleagues, I know that I rely on my colleagues very often, my other palliative care provider colleagues or my oncology colleagues, to just share sort of the burden, have other people who understand and other people who can understand and relate to the difficult emotional toll it can take on you to care for really sick people. And I think oftentimes for us as clinicians, even though we might intellectually or rationally know that, people get sick, these are serious illnesses, not a personal failure on our part if someone has a bad symptom or doesn't get better or ends up passing away. We can take that really personally. It can feel like a failure, and to have someone you work with to kind of share that emotional burden of not feeling so alone in working with people in really sometimes really sad or difficult circumstances, or circumstances that doesn't go the way you or sometimes the patient or family expected and hoped that it would, can be helpful. I think oftentimes in palliative care too, as a team, one of our team members do things like lead debriefings. If there have been particularly traumatic patient circumstances, we might lead debriefings. We might, it sounds sometimes kind of funny, but at the beginning of all our team meetings, one person is assigned oftentimes to read a poem or share a song that is important to them, and just to connect with each other on a more human, personal level, because so much of our day is just go, 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 busy, busy, busy. I will, Suchila, if it's okay with you, I just have a couple more slides, and I want to make sure we have time to for Margaret to give her full presentation, but I will certainly try, I certainly hope that I think as we go through that I'll answer this question about the major role in end-of-life care. I think the role of rehab in palliative care, I think, is huge, and it goes back to quality of life. Before I think I had this job, and one of the first people I met when I started, one of the first people I met at this when I worked in this position was spending a few days a day shadowing with Margaret, who's a member of our palliative care team in physical therapy. And I was so amazed at the kind of intervention she had in terms of pain control and fatigue management and managing shortness of breath and things like that. So the role of rehab services and symptom management can be really dramatic in terms of helping with pain management, with shortness of breath, with fatigue, training around energy conservation, and helping people to maintain their mobility despite the fact maybe they do have some physical limitations. They're getting weaker, or they have edema, or they have shortness of breath. How do we work to keep them safely ambulating or mobile, even if it's like bed movement, to prevent bed sores? The role of speech language pathology in helping with communication. Sometimes I work with a lot of head and neck cancer patients, and they've had surgeries, or they've had laryngectomies, where they have permanent trachs. And so training them with electrolarynxes, training them in how to resume oral feeding, helping people who have cognitive difficulties as the result of, we talk about chemo brain. A lot of the medicines we use in cancer specifically can have I apologize, my son is coming in. I feel, oh, buddy, I'll come back in 1 minute. Sorry. This is Gregory. So, hey, buddy, I'll be out in 1 minute. Okay, can you tell me very quickly?
I bumped my head on the metal.
You okay, though? Good. I'm so sorry. I very much apologize. It's a little after 5:30, and I tried to give him a snack, but the kids are hungry. So thanks for your kindness in advance on that. In terms of, I often talk with my patients and try to proactively encourage, proactively encourage them to see Margaret and her colleagues in PT, because as I've gone through, working now with this population for about 5 to 6 years in the hospital before coming out to do my outpatient practice, you realize how valuable it is, how early in people's treatment they start working with rehab services around maintaining their strength, safe mobilization, appropriately identifying assistive equipment like walkers and or canes or things. I work with many people who have neuropathy from chemotherapy, and working with OT around both pain reduction and continuing to be able to do things like do their zippers and their buttons and type on their phones. Texting is so huge, and I talk with people who've lost the ability to text because of neuropathy, and OT and PT have such huge roles to play, and those are so intrinsic to people's quality of life. And I know Margaret is going to delve in a little bit more to the research there, but I am so grateful to have my rehab colleagues to refer to, because you just have an intensive set of knowledge that sometimes I don't have, but I know it means so much to people. As we tie up here, I want to talk, next slide, please. Connie, the last slide I have here, and someone asked about this, clinician role in palliative care. So clinicians trained in palliative care. Now there are some fellowship programs for physicians. They've grown super rapidly. Let me find my statistics here. So in 2013, there were 105 specialty fellowship training programs for palliative care physicians across the U.S., training about 288 palliative care certified MDs per year. By 2021-22 academic year, which is the last year for which we have statistics, there were 156 specialty palliative care training programs and 518. Were you able to make your announcement, Passakorn?
Okay, sorry. Please go on and just announce to another person in the meeting. Sorry.
Oh, okay. I apologize. So the 156 programs trained 518 MDs. So basically 50% more programs over the course of about 10 years and almost doubling the number of physicians trained. The first palliative care specialty program started in 1989 at Cleveland Clinic. And again, really hospice, initially hospice was the impetus for that. Hospice hugely in 1983 in the US when Medicare, which is the US's program for those 65 and older, started covering hospice services, and that led to an explosion of interest and availability of hospice. And so starting after that, we recognized the need for specialty trained hospice clinicians, and that kind of led to the 1989, the initial fellowship program. And as people became more aware of some of the symptoms that people living with serious illness dealt with, the idea of a palliative care specialty that wasn't just for end of life took root, and that is sort of the basis for palliative care. But I think, Suchila, I think many hospice and palliative care trained physicians and nurse practitioners, my certification is through the Hospice and Palliative Nurses Association. So my specialty certification is as an advanced, which entails some additional as well as testing regarding my proficiency in symptom management and communication. But many palliative care trained physicians and nurse practitioners also work in hospice. In the hospital setting, at least in my setting, palliative care often takes care of patients as the primary team for people receiving something called comfort care, which is comfort-focused care if people no longer have aggressive treatment goals, but perhaps maybe they're too sick to be discharged from the hospital. Their symptoms are too great, or they're just getting sick so quickly we can't facilitate comfortable transfer to them, so they're dying in the hospital. The comfort care, the palliative care team will often take care of them in the hospital. There's also a separate inpatient hospice group. So occasionally there are patients who do hospice in the hospital. Typically hospice is delivered in the home setting. And again, that may be by specialty trained nurses, social workers, physicians and nurse practitioners who manage symptoms in the home for people at end of life. In my role, I prescribe medications for symptom management. I assess people's understanding of their illness and work on development of advanced care planning documents. So that may be things like discussing who they would want to be a decision maker for them if they were ever in a situation where they couldn't verbalize their own medical decisions. We call that an advanced directive. We also have something called a physician order for life-sustaining treatment, which may be used if people would not want things like CPR. And so that sometimes is called a DNR order in other states, but I talk with patients around some of the issues for advanced care planning as well. And if you are interested, I have a few references that are some of the places where I got my statistics today. And just in summary, last slide, please, Connie. Palliative care has been shown to improve the self-assessed quality of life for people living with serious illness and sometimes even prolong life. Specifically for cancer patients, certain kind of cancer patients, people report improved understanding of their illness and improved communication with their healthcare teams. There's some cost savings associated with it. And rehab services specifically can be such an important component of palliative care because of the improvements in symptom management without the side effects of medications. I use a lot of medications for pain management that cause a lot of side effects, but Margaret's interventions don't have any side effects. They just improve pain. Help patients staying safe at home, preventing falls. For so many people, quality of life is so important. Being at home, being independent is important. And so those are some of the benefits of palliative care. And I thank you so much for your time. And I know Margaret has lots of good information for you as well.
Thank you, Andrea.
Thank you so much for having me and for putting up with my child coming in.
No worries.
Some of you can probably relate. That's true across the world.
We see your slide now, Margaret.
Yeah, Connie's driving my slideshow too. Connie, you there? Connie?
I think they're up, Margaret.
Well, they're up, but she should have it in slideshow mode. There she goes. There we go. There we go. She's like, thank you very much. So the role of rehabilitation in palliative care. So I like to sum it as the role is to maximize function while minimizing symptom load. I've been doing palliative care now for over 30 years. I actually started in palliative care working with AIDS patients and HIV positive people. And then that expanded the field into cancer, COPD, other chronic diseases, autoimmune diseases, and those things. So if you'll advance the next slide, Connie, please.
Can you speak up a little bit too? You're a little quiet.
A little quiet? All right. Is that better?
Yes.
Okay. So Esquadre et al. In 2018, they did a review of cancer rehab interventions and exercise programs specifically applied to patients with life-limiting conditions. The common issues for patients were fatigue, pain, dyspnea, self-efficiency, cognition, self-care, and functional mobility. Next slide, please. So the things that led to functional mobility issues were weakness, decreased endurance, depression, which is quite common in people who have chronic disease processes, pain, fatigue, and risks of fall. Next slide, please. So when assessing risk fall, you really want to look at what medications they're on, what visual impairments they have. And I don't know if you're aware that even people who wear bifocals or progressive lenses, like I do, have 50% increased risk of fall just by wearing those kinds of glasses. Orthostasis, balance, cognition, and environmental hazards. So at home, do they have stairs? Do they have throw rugs? Are there extension cords? Is there a lot of clutter? So kind of getting an inventory of what the house is set up like is important. Next slide, looking. And fatigue management. Exercise programs for patients with cancer have been shown to decrease fatigue, reduce insomnia, improve cardiovascular function, improve immune function, and promote well-being and respect. Exercise should be moderate to vigorous in intensity, at least 3 days a week at 60 to 85% of maximum heart rate for at least 30 minutes, and should include resistance training and balance training. Cade Fitness in 2017 did a systematic review of exercise interventions for individuals with advanced cancer. There were 26 total studies reviewed. The findings included improved aerobic capacity, increased strength, improved fatigue, improved dyspnea, and improved quality of life scores. In Corpora et al. In 2021 looked at the effects of guided imagery and hand massage on well-being of pain in patients in palliative care. So it was a pilot study of 20 people. Both interventions were done at the same time. So they had 20 minutes of guided progressive relaxation, and then each hand was massaged with lavender oil for 10 minutes. Findings: the intervention had an immediate positive effect on well-being and pain levels in the palliative care patients. And to me, this makes total sense, because if you remember the homunculus, how big our hands are on our brain, working with people's hands is a great way to calm down the central state. And the other thing you may not be aware of, but lavender actually happens to be a low-grade narcotic. And that's why a lot of people with migraines will cover their eyes with lavender eye coverings when they have a migraine to reduce their migraines. So Mid-Spirit in 2019, they did a comprehensive review of studies investigating pulmonary rehab and exercise training. So one study was a randomized clinical trial that just demonstrated the benefits of intense pulmonary rehab maintenance exercise program on 6-minute walk test, body mass, airflow obstruction, dyspnea, and exercise. And those scores were maintained up to 2 years later. And another study showed reduced risk of readmission rates when pulmonary rehab was delivered early following hospitalization. Another study showed increased physical activity in a 12-week program of exercise and weekly telecoaching, whereas pedometer-directed footstep targets did not change physical activity. So I think that accountability when you're having to meet with a coach, telecoach every month, every week helps people stay committed to their programs. But the other part about coaching is when done well, you're really tapping into the person's individual motivations for wanting to get better and what values they can live out by getting better. So that telecoaching, I think, is really important. So I have a question over here. I have a 76-year-old patient who has underlying autoimmune hemolytic anemia. He needs to take steroids quite a long time, and his hematocrit is always lower than 30%. He needs assistance in both ADLs and ambulation. What exercises can a therapist do for him? Is it necessary to provide oxygen supplement while doing exercises? So we will supplement for oxygen if the O2 sats fall below 94% when they're exercising. So what you would still want to do with this person is you can use the Bohr Perceived Exertional Scale, and you'd want them working in what they perceive as a moderate range, so that would be a score of 14 out of 20 or 6 to 7 out of 10. You wouldn't want them working harder than that. So you're going to really base it on how their perceived exertion is for them. because that could be somewhat variable. People can have chronically low hematocrit, but actually become much more active. Corsaro in 2017 did a randomized control study physical therapy program to reduce fatigue in patients with advanced cancer receiving palliative care. They had 60 patients total and were divided into the treatment group and control group. So the control group did not get any physical therapy. You sit in a row. So where the interventions were active exercises, myofascial release, and PNF techniques. The results, a significant reduction in fatigue scores for the treatment group, improved patient well-being, and the other benefit was the reduction of coexisting symptoms such as pain, drowsiness, lack of appetite, and depression. Hogdell in 2020, this was an OT-PT intervention in palliative care cross-sectional study of patient needs reported. So they surveyed 43 patients total. They measured 12 symptom problems. On average, patients had characteristics like 6 of 12 symptom problems as severe. So the most common was fatigue at 81%, impaired physical mobility at 77%, the ability to carry out work and daily activities 77%, pain 72%, worries 58%, and dyspnea 44%. So the conclusion, patients referred to specialized palliative care teams reported extensive unmet needs concerning physical activity, work and daily activities, fatigue, pain, concentration, and worries. And these unmet needs could potentially be alleviated by OT and PT involvement. So I want to talk a little bit about pain management because fatigue and pain management are probably the two most common things I do. So I use a lot of dermoneuromodulation. So for those of you who watched Bill and I's webinar last year on this, I do a lot of work, particularly with their hands and around their face. And I teach them how to do it for themselves because it is very soothing. Neuroglides. So the glides I use most common would be the sciatic nerve glide and median nerve glides. Then there's actually a glide for cranial nerve 5 and 11, which is essentially like an upper trap stretch on, off. And I have them verbalize a deep O when they do that because what I'm getting is modulation of cranial nerve 5, 11, and 10, which really calm down the central state. And I have that do that throughout the day because the calmer their brain is, the less pain they have. Craniosacral therapy. And so essentially craniosacral therapy is a technique that actually amplifies parasympathetic nervous system. That means that the patient's means which act as pain inhibitors. Myofascial release. This is particularly helpful with people who have graft versus host disease. We see that a fair amount in our bone marrow transplants. Strain counterstrain, which is a positional release technique, which is indirect, so it's perfect for this population, so you won't break them. Muscle energy, which is also an indirect type of manual therapy technique. I use TENS a lot. I use that particularly for people who have bone nets. I find it really helps them sleep better, be more mobile and active. I use microcurrent, which is a direct current for people with neuropathies. It's shown to help stabilize nerve membranes and promote healing of nerves. It decreases inflammation and also promotes soft tissue healing. So if, say, somebody has developed a stasis sore or a bed sore, microcurrent can help that heal much quicker. And its therapeutic range is between 10 and 50 microamps. Progressive relaxation, meditation, music therapy can be extremely helpful for people. If you look at the music therapy literature, they have seen great reductions in distress and improve well-being with music therapy for people with cancer and other life-altering disease processes. Visualization, proven reflex inhibition techniques, and this is another form of manual therapy developed by John Lamb, who's a PT in California. And a lot of the techniques that we can share with the patients that they can do on themselves to decrease stress within their systems.
Is primitive inhibition technique? Can you show one?
So I can show you a couple in that the two that are most powerful are inhibition of primal palmar grasp. And so what you would have them do is that you have them put their thumb inside their hand and then the other hand over the top. And you have them try to open their hand into their other hand while I'm going to tap on the hand that's trying to open. And for about 15 seconds. And I do both hands. And the test is if you pinch them here, not hard, but that it's to be tender, and then when you're done, it's no longer tender. And then the self-treatment of that is that you displace the ring finger away from the palm. And they do that anytime they're feeling stressed or anxious. And so what that does is it interrupts that reflex and gets their blood flow back in their brain where it should be. Because when you're stressed, your blood flow shunts away from your frontal cortex, where that's the part of the brain that makes you human. Those are your relationships, your ambitions, your executive thinking. You send it back to the hypothalamus, which is part of your monkey brain. So, and it cares about 4 things: food, fear, fight, flight, and sex. So we want to get that blood flow shift back to the frontal cortex because that has some really powerful inhibitory effects on pain and stress. So that would be one of those techniques. All right, I have a case study for you. So this is a 36-year-old female who has Ehlers-Danlos syndrome, which is a form of hypermobility. She has postural electrostatic tachycardia. She has joint pain due to Lyme. And I don't know if you all have Lyme in Thailand, but it's quite common in North America. It's a tick-borne disease. She has dystonia, depression, anxiety, migraines, and mast cell activation disorder. So for those of you who watched the German neuromodulation webinar, she's the case study I talked about who came walking into the clinic, literally walking with her dystonias of bed, literally walking on her lateral malleolus and her arm all flexed up. And by the time I was done doing German neuromodulation, she walked out of the clinic normally with her cane. So that's who we're talking about. Initial eval was in December 2021. At that time function, she could sit for 30 to 60 minutes, but then she would have to lay down for 5 hours. She had cervical, spinal, and SI joint instability. She had positive Romberg, so her proprioception sense was very impaired. Positive slump test, so she had adverse neuroretention. She had intermittent dystonia throughout the eval and mild vestibular dysfunction. Her patient-specific functional outcome scale was 4.7. So the treatment included a whole body stabilization program, and I always start with the cervical spine because if it's not stable, you're not going to get good results with anything else because your neck's the information highway. Everything command that goes down and every sensory perception that comes up. The other thing we have to do is when the neck gets stable is because whenever we have these blood vessels come back to our head, we have some important sensors back here: heart rate, blood pressure, vision, digestion, balance. So we need to stabilize blood flow to the brain. So I always start with cervical stability and move my way down. Manual therapy techniques included muscle energy, strain, counterstrain, craniosacral therapy, visceral manipulation, and primal reflex inhibition techniques. So visceral manipulation is a good trick to have in your bag because with mast cell disorder, you get sticky in all the wrong places. So what will happen is the fascia in which the organs live in becomes restricted and they don't have the natural slide glides, and that can contribute to pain and dysfunction within the organ systems themselves. The mountain pose for POTS, and I have to give this nod to Connie. She sent me an article a couple years ago on syncope, and these people who had poorly controlled syncope, even with medication, they gave them the mountain pose, and that significantly reduced episodes of syncope. So I was like, all my POTS people need this. So if you're not familiar, what you do is you're standing, you raise your toes up, then you raise your heels up, then you contract your quads, your glutes, suck your navel in, and then you breathe in and bring your arms up over your head, and you hold them for a couple seconds, and you relax. And you repeat it 8 to 12 times every day. Now, if a patient starts feeling POTS, I have them do it right away. It short circuits it, and they never go into full POTS. So all my POTS patients really love this. This is one they'll usually get on initial eval. Heat management strategies. Because of that POTS, she's very heat intolerant. So that included looking at cooling garments like a cooling vest, cooling wraps, making sure she had ice water handy. If she's going to exercise, have a fan going. The other important part about this, when you heat up, remember your blood vessels vasodilate, and so your blood pressure drops, but also your blood sugar drops because your blood sugar goes out to the periphery with the flow of the blood. And so many of the symptoms of low blood sugar are similar to the symptoms of POTS. So you want them to have like a trail mix always available that has a quick sugar with a fat and protein to get them up and then stabilize it up. So self-management strategies and modulation of the vagus nerve. So self-pain management strategies include self-seating roar. So that was the tennis balls behind the head from that headache lecture last fall. Dr. Warnerpaw is still using hers. Self-mobilization of the sphenoid bone, and that is the cornerstone bone of the cranium. The only way you can get it from the outside is right here at the corner of the eyes. She has a lot of allergies, so it would get stuck, so she needed to be able to get it unstuck by herself. Neuroglides, so that the sciatic, median, and the upper trapet, the ah. Self-dermal neuromodulation of her hands, her face, and her SCNs, because her SCNs were very involved in her dystonia. And self-mobilization of her cubes. So even despite being on a good stabilization program, because of the hypermobility, they can get some shifting on the pelvis. And so the the cues and get themselves realigned. That's a real important piece. So she's had a total of 16 visits to date. Half of them have been virtual because we started in the middle of the pandemic, and she, at that time, was severely immunocompromised. So we did a lot of work virtually first until the pandemic kind of waned and her immune status improved. So she's now coming into the clinic. So she improved to the point that she was able to travel successfully to Brazil alone. And this is major because this was somebody who was almost totally housebound by her disability. And in fact, she's doing so well. She's leaving for Brazil this month and will follow up with me in December when she returns. So it's been really exciting to watch her stabilize out. She committed to the program and really has followed. So the quality of her life is quite expanded. I want to talk a little bit about self-care because there was a question about burnout earlier. And because if you don't have good self-care, this kind of work can chew you up and spit you out. So I think some important aspects of self-care are having some kind of meditation or spiritual practice that you do on a very regular basis. Good sleep, and a good life-work balance. I probably should also put here, swim in good pools of people who have good energy, that like to have fun, that renew your spirit and soul. I know if I'm having a particularly hard day in the clinic for whatever reason, I go find Bill, and Bill gives me just the best bear hug you ever had. And that always makes me feel great. So I think it's really important to have those resources. Thank you. Any questions?
Thank you for your lecture. Could you hear me?
We can hear you.
Yes. I just want to ask, in the US system, I think you have the hospice care as well. So what difference between hospice care and the palliative care system?
Okay, so hospice is end of life, whereas palliative really is across the spectrum of your life with a chronic disease process. So, when cancer is where it's most noted, so a lot of people I see very early in their cancer diagnosis, all right, and help relieve symptom load for their chemotherapy, their radiation. I have one gal who's been living with liver cancer for, I've been working with her now 5 years. And she has metastatic disease, but she's not terminal. Will the cancer eventually kill her? I don't know. But she's has a mother, has two not small anymore. One's going to be going into middle school, one's in elementary school, and her husband. And so she would be a great example of the difference between palliative and hospice. Right? She's not nearly close to hospice. She may one day need hospice, but that might be next year. It might be 2 years, might be 10 years, because with the type of cancer she has, the prognosis isn't great. She's beaten a lot of the odds, and she's doing quite well right now with the treatment regime she's on. So I don't know from that standpoint. A lot of my people with rheumatic conditions like lupus, severe Crohn's, again, these can end up being eventually transferred to hospice, but there's a lot you can do to manage their symptoms of pain and fatigue throughout the course of their care with having something like lupus that can affect every organ system.
We routinely, in fact, in my practice, and I think probably in yours as well, Margaret, even though we are oftentimes working with palliative patients, it would be quite actually rare for either of us in our sitting to work with somebody who is sort of hospice eligible, but oftentimes we're working with people to help them maintain the ability sometimes to stay on treatment. So I work with people sometimes who are getting curative chemo and radiation therapy regimes. So for example, head and neck cancer, there is curative treatment, but the pain and fatigue and some of the symptoms associated with it, sometimes without palliative care, it's really hard for people to stay on that treatment. And so we work with people oftentimes who are still getting treatment, who wouldn't be eligible for hospice. They're not at end of life. To qualify for hospice, you need a prognosis of 6 months or less. And so palliative care is really care that can complement any care for somebody with serious illness through any part of their disease course to help keep them feeling good, to keep them healthy, to keep their quality of life as high as it can be.
What tool do you use to assess fatigue score?
So the APTA did a review of fatigue scores for the oncologist section did, and they looked at the cancer fatigue score. They looked at the 0 to 10 score on fatigue and a couple others. And really, all of them statistically were fairly close, but they really felt that in the clinic, depending on how much have you time to do outcome measures, that using 0 to 10 is just as effective as using the cancer fatigue score. So I use 0 to 10. So 0 would be you have absolutely, you're peppy. 10, you can't get out of bed. So it's opposite in some ways. Well, no, it's the same.
Same as pain score.
Yeah, so it's the same as the pain score in that way. So
Did you, Andrea or Margaret, did you answer Who plays the major role in end-of-life care? Is it the physician?
It depends upon where the patient is located. I mean, I think in a hospital setting, which is for many people, you know, they want to be, if they have a serious illness and it has been a predictable illness and they know they're approaching end of life, many people want something like hospice care because they prefer to be at home. And in hospice care, it's really a very much a team approach with your hospice nurse, oftentimes a medical assistant, oftentimes a social worker, although ongoing physical therapy and OT and respiratory therapy, there aren't typically ongoing therapies. There's very frequently, again, for somebody with shortness of breath, there may be somebody helping to do some chest PT or doing things to help with discomfort at end of life. So it's hard to say. I mean, in the hospital, it's probably typically nurses and physicians doing the hands-on care. In a home setting, oftentimes family, but with significant assistance from a variety of home hospital kind of personnel.
And Margaret, POTS, what does POTS stand for?
Postural orthostatic tachycardia. So you'll see it a lot in your long COVID patients.
Okay.
And
you have another funny question from Dr. Wanapa. How often do the little finger stretching for anxiety? How long to make it work?
it usually happens in a couple of seconds. People just kind of feel a relaxation. But if you're having a particularly stressful day, or you're talking to somebody who's obnoxious, or in a meeting with obnoxious people, put a pin there. Because what you're telling yourself is they're obnoxious, they're not tigers. All right?
Oh no, I hope Dr. Wanapa doesn't have to do that every day.
Okay. Okay. So that doesn't have to do like 5 minutes, 10 minutes, right? It's only
Just, you know, some people will just interlock their ring fingers when they're just sitting, you know, because it just kind of calms them down. So it's somewhat variable how often people do it. In the beginning, a lot of times they'll do it much more frequently because their system has to take a while to keep learning to calm down. But once they've been doing it on an ongoing basis, the need for it isn't as frequent because their nervous system isn't so jacked up high in this fight or flight panic place.
Hey,
okay.
Margaret, in a session of the patient who has stable chest problem, could you please share the PT and OT program? And we have like 1 or 2 minutes.
Well, I have a question. What do they mean by stable chest problem? Elaborate for me.
A ton.
Okay, hello, Margaret.
Hello.
I'd like to know that if the patient who have like a sputum or who can breathing by themselves, but have to encourage coughing technique, but exercise easy to fatigue or a bit tired, about the chest PT program or the PT program can improve their life, the quality of life in each day.
Yeah. So this is somebody who I probably would mobilize their rib cage. And what we want to do is actually make the rib cage smaller. A lot of people want to make it bigger and try to open it this way. Actually, if you will compress it in and hold it, you will feel a relaxation response. And then it can expand out. Because what happens is they get kind of stuck out instead of being able to go in and out. Slowly get rid of the stale air and create room for the new air. So I work with them. I want them, their respiration rate to their exhale should be 1.5 times their inhale. So getting them to, like when they walk, then they'll inhale 2 steps, exhale 3 steps, breathing in through their nose, out through pursed lips, because that pursed lips is going to create a negative back pressure to keep the bronchioles open. And so I'll work on how to walk and breathe at the same time. I like to use D2 bilateral PNF where they're coming down and they are opening up wide, breathing in, And then to come out, exhale down, pierce lips. Because again, it's that we bring the arms up and out, we're increasing the negative pressure system of the chest. So that allows respiration to be much more effective when we do it. So that's one of my favorite things to do as well. There are visceral mobilization techniques that help you mobilize the pleura around the lungs and mobilize between lung lobes that sometimes can also help with the capacity of the chest to function better.
Okay, I love this because Dr. Sushila and Dr. Monapa host us all the time. So Dr. Sushila's last question, Andrea, do you ever see a conflict when who's the one who initiates that end of life care, whether it's a family or a provider? Do you want to kind of talk about that?
So we always, part of our standard communication, we do a lot of training around communication. So I do a lot of permission asking. I'll start out by asking, what is your understanding of your illness? And I'm specifically talking about kind of end of life conversations, or even a conversation where maybe we open the door to talking about limited treatment options or discussions of hospice or changes to goals of care. We'll start by asking what people's understanding is, then asking kind of what they want to know. So some people really don't want to discuss anything about prognosis. Some people really don't want to discuss anything about what they might experience as they get sicker and as they die. But some people have a lot of curiosity about that. So we'll try to assess what they want to know. I will oftentimes ask permission once they've shared with me what they understand. Knowing what they want to know, I will ask permission if I can share my understanding of their disease, and I can share. Oftentimes, we use frameworks like, some people in your position want X, some people want Y. Do you have a sense of what you might want? Sometimes we might ask, are there differences? Like, some patients say, I don't want to talk about prognosis, but it's okay if you discuss with my family. So sometimes if I'm having end of life discussions, I might discuss separately with the patient and separately with the family if there is a difference between what they want to know. I will, but yes, I mean, sometimes there is conflict between family. There, especially in cancer, there's a lot of, I think, language around fighting and never giving up. And so it can feel to people like they're giving up, or it's a defeat if they have to stop treatment, or if they focus on symptom management rather than aggressive treatment. And in those situations, I'll often share, we might reframe, talk about, well, I know, what is it that you're hoping for? Is your hope for more treatment, or is your hope for more time with your family, not being in the hospital? Those kinds of things. I might also share some of the information, some of the research out there about the fact that for people with advanced cancers, and there's a lot of nuance around here and caveats, but for people with advanced cancers, basically there is no evidence that there is that there is decreased survival for people on hospice versus people getting additional aggressive treatment, clinical trials, third and fourth and fifth line chemotherapy in the setting of diminished performance status. And there's lots of evidence that those patients report higher quality of life on hospice versus if they're getting care. The only studies for cancer patients specifically that show a survival benefit to treatment or hospice actually show the survival benefit for hospice. And we think we're not sure that isn't true across the board, but several studies have shown a statistically significant survival benefit for hospice for advanced cancer patients on the order of maybe, not huge, 10 to 20 days, but also in the context of higher self-reported and quality of life and less family reported distress. And so with permission for patients, I will often share with them that, if what their fight is for the longest possible life and the best and the highest possible quality of life, sometimes a switch to hospice goals may help that. So there are a lot of really good communication techniques that we talk to with that we frame how we frame difficult, potentially conflict or contentious discussions, and so I try to use those, but I try to do a lot of asking for permission to share what I understand and trying to understand what their understanding is so that I can kind of best craft the information and my goal is never to make them choose a certain thing, but my goal is to understand what they want and help design a class that gets them what they want.
Thank you. Thank you.
Thank
Andrew
you.
and Margaret, you are amazing. Wonderful. And Dr. Wanapad, you want to close us out?
Yes, I think we are a bit over the time. So sorry to trouble your evening time. We learn a lot as always, and we hope to hear you again in next month. Thank you. Bye-bye.
Bye-bye. Sawadika.
สวัสดีครับ
สวัสดี
Thank you
ค่ะ
very much
Thank you all.
Thank you, Dr.